It's my pleasure to introduce Dr. Kamal Pohar, who is the department chair, professor and chair at the University of Cincinnati Department of Urology. We were colleagues together at Ohio State University, and he's going to give us his talk on bladder cancer. So, turn it over to you, Dr. Pohar.
Great, thanks very much. Well, I appreciate the opportunity to speak with all of you this evening. The talk was pretty informal. What I'd like to do is I want to talk about broad principles of managing a relatively complex space of non-muscle invasive bladder cancer. As Dr. Jenkins mentioned, I was at Ohio State for many years on faculty, and some of my slides have some Ohio State logos on them, so please excuse them. I've only been in my new position about 10 weeks now. So I think a good starting place, as all of us as practicing urologists, I think a good starting place are the AUA guidelines. And I've taken 2 points that have been present in the guidelines for a considerable period of time, that we should always start an endoscopic bladder tumor removal surgery with a thorough cystoscopic examination. We should thoroughly evaluate the urethra, the bladder, document the location of abnormal pathology or tumors, size of tumors, number of tumors, other mucosal abnormalities, and so forth. This is an important clinical principle. Once we have a good understanding of the underlying problem or the anatomic situation at hand, performing a complete visual transurethral resection of all abnormal pathology tumors when it's technically feasible is another important clinical principle. But certainly it's not an easy operation. I think why I want to emphasize the fact that performing a TURBT operation, I personally find one of the more challenging operations every once in a while. Some of these operations can cause a lot of angst. Quality of the operation is real important, and I'm not going to go very deeply into the literature today to really demonstrate how much an individual provider or urologist, that there's evidence to support the fact that who is performing the operation also influences the outcome of the patient in terms of important cancer outcomes other than just the pathology of the tumor, the stage, the size, the number of tumors. The actual performance or conduct of the operation has an influence. But we all know that TURBT is suggested to have better outcomes after intravesical therapies, better outcomes for individuals undergoing chemoradiation therapy for muscle-invasive bladder cancer. And there's a suggestion that a better quality TURBT may possibly lead to less presence of residual cancer after neoadjuvant chemotherapy in muscle-invasive bladder cancer patients. So there is a quality matters. Now, my first few slides, what I'm going to share is I'm going to demonstrate various efforts of looking at a population level, looking at a regional level, and looking down at an institutional or provider level, that we can all work on getting better, myself included. The operation has significant benefit to a patient. It can improve outcomes. Quality of the surgery is important. And there are various ways to measure the quality of the TURBT operation. So this is a study that was performed in Scotland. Scotland has a health care delivery system that is different than our way of care in the United States. It's directed by at a public level. It's paid for by federal healthcare dollars, and the conduct of how healthcare is delivered is different. So the country decided they wanted to invest in a quality improvement program around bladder cancer management, and with a focus on the TURBT operation. And quality parameters that they felt they needed to focus on after doing an initial study of a cohort of individuals treated in Scotland that predated the implementation of their study, and looking at quality parameters in the literature, they felt that at every operation, the urologist should be using a bladder diagram. they wanted to evaluate was the single dose of chemotherapy post-TURBT being administered, was muscle present in the resected specimen, and was an early repeat TURBT when indicated in high-risk non-muscle invasive bladder cancer patient, was it being done in a timely manner, meaning within 6 weeks. And so they implemented a program of sharing this with urologists practicing in the country, that they wanted to measure these parameters. They wanted to provide feedback on a semi-annual, annual basis, blinded, to just instruct individuals and the practitioners as a whole on where were metrics when they started the study and where were metrics as the study went on. And so they measured quality performance indicators as well as clinical deliverables. You see them on the slide: the recurrence rate at first follow-up cystoscopy, rate of residual cancer at repeat TURBT, and really looking at the likelihood of understaging. Was muscle invasive bladder cancer missed at the first TURBT? Importantly, I should have mentioned, these were patients with a first-time diagnosis or suspected diagnosis of bladder cancer. So these were not patients that had a prior history or had recurrent tumors, but rather patients that were diagnosed de novo for urologic workup. Tumors or pathology was identified, strongly suspected to be bladder cancer. There's a busy slide, but I want to just share some highlights of the data. So the top box there is really looking at the country as a whole, years 1, 2, and 3, and 3 of their quality performance indicators are demonstrated there. Was a diagram being used? Was muscle present? Was the single dose of perioperative chemotherapy being given? And again, data was being shared across the country as a whole with practitioners. And you can see the spread of the data. Were things changing much or not changing much when there was some kind of government type of regulation? There was a cohort they were following in a region. That's what the second box is about. In years 1, 2, and 3, the same parameters. You can see for yourself, how much did this truly influence the way that urologists were practicing the delivery of care. And then finally, the bottom slide are 3 different hospitals groups. So A, B, and C. These were hospitals that were made up of urology faculty, or what's referred to as consultants in Scotland, versus trainees or residents, were comprised these 3 groups. And you can see again the use of a bladder diagram, detrusor muscle, or perioperative chemotherapy. And this was in the 3rd year of implementing their cohort. This is where they stood in the 3 hospital systems. And you can see they demonstrated that over their 3 years, what some of their data was in terms of recurrence rates, residual cancer rates at repeat TURBT, and understaging. And these are all numbers that in general we would think this is pretty good quality TURBT with residual cancer rates and understaging of that degree. So overall, it seems to be that the quality of surgery is reasonably well throughout a whole population. I put this slide up to demonstrate the red are attending surgeons or faculty, the black are trainees or residents. And you see it's these 3 hospital systems in year 3. And you see that the trainees, in terms of recurrence rate at first cystoscopy and residual cancer rates at repeat TURBT, the trainees not often, or at one of the hospital groups had better outcomes, equivalent outcomes at another hospital group, or slightly not as good as the consultant. So anyone can get better. There's room for all of us to get better, that focusing on quality of TURBT and how we go about doing it impacts patient outcomes. And I think it's real important to recognize how critical that is to providing the best outcomes for non-muscle invasive bladder cancer patients. So what are ways we can do it? There are many writings, descriptions, simulation models that have been published to try to allow us to all get better. I take a fairly simplistic view. And this is something I've been utilizing in my practice for many years. It's a quality checklist. And what this checklist was developed by institutions that are very much known for their bladder cancer care. So these are several academic institutions that have very um, dedicated bladder cancer programs, and they got together and they wanted to measure their data. Individuals who were considered to have practices that highly focused on bladder cancer, what was their current ability to document and deliver variables that we know impact non-muscle invasive bladder cancer patients' care positively, and was there room for improvement? And I'll show that to you on the next slide. What their intent was were they obtaining the information necessary for accurate classification of clinical stage and cancer risk at the time of doing the surgery? Were they actually performing and documenting a complete surgical resection of all signs of disease? Were they doing it in a safe and feasible way? And what was the quality of the operation at the end? Was there any signs of perforation? Was there muscle present? And they came up with a checklist that's really easy to implement in medical practice. It has 10 variables there. And these variables, they measured before checklist implementation. And you can see the percentages there of documenting number of tumors, the characteristics of the tumor. Did they do a bimanual exam before they started the TURBT, post TURBT? And you can see in the hands of individuals who have practices that are highly focused on bladder cancer, there's nowhere near 100%, 90%, 80% in most of those variables. So the group clearly recognized there's room for improvement. So it was discussed as a body of practitioners, centers got together, they put together a study and formulated, we agree these variables impact patient care positively as we're making decisions and providing high quality care. And you can see when there's some dialogue, there's some observation, there's some measurement of parameters. Are we improving? You can see how much better the individuals demonstrated they could all become over time. And so it's something I utilize in my practice. And I kind of measure myself and understand even almost 20 years in practice, where am I at with quality parameters? And I recognize there's always room to get better. Another busy slide. I'm sorry for a busy slide. I just want to highlight a couple of details. The specifics aren't that important, but I want to bring this down now, not from a population-based level or a government observation level to a regional or a whole institution working together. But this is one individual that's highlighted. This is a study from Northwestern. They looked at 11 surgeons that practice in their health system that did TURBTs for bladder cancer care. They looked at just the presence of muscle in the specimen, only one variable. What was the percentage of that? They recognized it was below a standard that everyone desired and hoped to achieve. So they implemented a report card that they would share with surgeons in a blinded manner and with the group in a manner that you wouldn't know the data for the other surgeon. And there's one surgeon that I highlighted here, surgeon number 7. And you can see before study implementation 2006 to 2009. They started talking about it in 2010. They implemented their scorecards. You can see the individual, the number of TURBTs didn't change in the individual's practice, but the presence of muscle continued to get better and better and better in T1 bladder cancer patients at first diagnosis. So you can see that if you're invested in an effort to get better, we can all improve. Okay, I'm going to move on to another topic. I'm going to move away from emphasizing non-muscle invasive bladder cancer management starts with a thorough cystoscopic evaluation and really doing your best to be diligent at removing all signs of visible cancer and really documenting factors that are important when you're making treatment decisions, number of tumors, size of tumors, and so forth. And I'm going to come back to some of that. This is a very historical slide. I've carried this around maybe because I put a lot of effort into making this slide as a junior faculty member. I have a hard time maybe letting go of this slide to some degree. But this is very classic historical data. This was before we brought forward a number of actionable ways to improve how we're treating bladder cancer patients. And I'm going to highlight several of those as I walk through the slides. So this is really white light TURBT, doing the best you can and moving forward with care. This is a historical slide. You can see the recurrence rates. If you look at grade and stage, regardless of grade and stage, with long-term follow-up in the range of 10 to 20 years from institutions and urologists who were well known during those eras of being world experts in the area of bladder cancer, recurrence rates with long-term follow-up were atrociously high. Progression rates, similarly, were high. And naturally, this was influenced by grade and stage of the cancer more so than the recurrence rate slide. But still, you see progression was present in all groups and very, very high in the high grade T1 group. So certainly there was a lot of room that we could improve. The slide's about 15 years old. The data is from 20 or 25 years ago. So many things have changed over that time. So after we perform a good quality operation, we want to sit down and talk with our patient about what's the risk of cancer recurrence in the bladder and what's the risk of cancer progression. These are things in our minds that we know are really important to that individual patient's future outcome. So as we're thinking about it in layman's terms, that's kind of what we want to present to the patient. I've done a high quality operation to the best of my ability. I have the pathology back now from the pathologist. I have my operative report. I used my surgical checklist. I documented all those parameters. So you want to be able to sit down and let the patient know what's my risk of recurrence and progression. Well, the EORTC, which is the European Organization for the Research and Treatment of Cancer, published a really nice study on almost 2,600 patients, all from randomized clinical trials in the non-muscle invasive bladder cancer space over a period of many years. So they had access to very good quality data. And they built a calculator to help practitioners. How can we counsel a patient what the risk of recurrence and progression are? So they had several factors in a multivariate analysis. They created a point scoring system that you could look at a given patient, how many tumors were in the bladder, what was the size, had they had prior recurrences, what was the grade, what was the stage, was there carcinoma in situ. You can assign points for recurrence and progression. You can add them up and you can put them in this risk calculator, and you'll be able to tell the patient at 1 year and 5 years, this is the probability of recurrence and your probability of the cancer becoming worse over time. Sounded like a very useful concept, very objective, would help us bring some ability to counsel a patient with some confidence. Unfortunately, all of this effort is really not practical in our delivery of care. The reason is the calculator is deficient because the population of patients that's used in the calculator, most of them had never received standard intravesical therapies, specifically BCG in the appropriate population. On top of that, not only were patients not receiving BCG during the era of these clinical trials, all of the other concepts that I'm going to highlight today, like what about enhanced cystoscopy? Was that used? How about repeat TURBT? Was that used? How about maintenance therapy? Was that used? So numerous deficiencies that the calculator is historical information. We don't use it in clinical practice, but a tool like this, in my view, would be highly valuable if we had a modern day tool that was utilized in a population of patients that receive a level of standard of care with technologies, quality of TURBT, duration of intravesical therapy that we all know about in our guidelines today, a tool like that would be really instructive to patients. And I'm sure we would find that our rates of tumor recurrence and progression have gone down significantly over time than the historical slide that I presented. And there's data that clearly shows now that that EORTC risk calculator overestimates recurrence and progression rates based on what we're doing today. But these are single institution reports or multi-institution reports that are retrospective, and we need stronger studies and better studies to build the right calculators and tools. And so I hope that happens. Okay. Um, let's take it a step further now in caring for patients with NMIBC. So I want to take a very general view. Why is it that recurrences happen? I mean, why do patients recur early or late with subsequent tumors? So I'm going to break it down into three broad categories. So the first one is persistent or unrecognized tumor at the time of the TURBT. That doesn't make you or I feel good, right? That's something we don't desire to happen during an operation. We do everything we can to manage that variable, that we're doing a high quality TURBT and removing all signs of cancer. But we know that that happens. And there are things we can enact in our practice, introduce into our operating rooms that allow us to be better at not leaving residual tumor behind. One is enhanced cystoscopy, and I'm going to share the AUA guideline statement for blue light cystoscopy. There's also a statement on NBI, which is evidence strength grade C. It's not as strong as a recommendation. It's a conditional recommendation. But in a patient with NMIBC, a clinician should offer blue light cystoscopy at the time of TURBT to increase detection and decrease recurrence. I think we all know there's a wealth of evidence that demonstrates that blue light cystoscopy not only sees additional tumors that white light cystoscopy may not recognize, but there are several studies that show that a clinically actionable endpoint like reduced cancer recurrence rates at follow-up cystoscopy. Blue light cystoscopy reduces those rates. So if it's available to you, you should be using it. The same with NBI. We don't have the data as strongly that it reduces recurrence rates, but no doubt you can see more tumors with narrow band imaging than if you just relied on white light cystoscopy alone. So there's no doubt we leave tumors behind sometimes at surgery because we just don't see them. And importantly, it's not like blue light cystoscopy is the end all be all, but it's a complementary technology with white light cystoscopy. There's evidence that shows up to about 8% of pathologically documented tumors are only seen by white light cystoscopy and not blue light cystoscopy. So they're complementary technologies and they should be utilized together. Another variable that I'll highlight from the AUA guidelines is our ability to not leave residual cancer behind. Well, one is naturally, I think one that's pretty obvious, and that's the one on the table, incomplete initial resection. A repeat TURBT is recommended in all patients if you know you left tumor behind, if it's technically feasible, and we're working on bladder sparing, and we're not going to proceed with cystectomy. So I think that one is just very straightforward. You should not feel sheepish about the fact that if there was residual tumor left behind, there was good reason. For whatever reason, that operation was stopped at a certain point in time for the safety of the patient, for the conduct of the surgery. There's no harm in coming back 3, 4 weeks later and completing the resection. It's real important that a high quality operation be done with the intent to cure non-muscle invasive bladder cancer. And TURBT is a curative operation. The second one, it's the bottom one on the table, T1 disease. I think we all know if we look up any guideline internationally, whether it's the American AUA SUO guideline, the European guideline, the Canadian guideline, the Australian guideline, and so on and so forth, it's highly recommended that a repeat TURBT be done in a patient with T1 bladder cancer at first TUR because of the high risk of leaving a residual disease behind microscopically, even when you felt you removed it all, and the risk of understaging even when muscle was present in the first surgery. So I think that's one we all have been advised by numerous guidelines, publications. T1 bladder cancer, you should do a repeat TURBT. And then the high-grade T1 patient, the high-grade TA patient population, there's a little more judgment there. I think you have to factor in how many tumors were there, what was the size of them, what was the location, was there muscle present in your resection, what's your level of confidence that you've truly removed all signs of visible and, to the best of your ability, microscopic disease. That's why there's a grade C recommendation. So that's another thing. In addition to using enhanced cystoscopy or blue light cystoscopy, you should be real thoughtful about the right patients. When should I do a repeat TURBT? No patient likes to undergo a repeat operation, but I think it's important they recognize it could be in their best interest. It is in their best interest, and you should be willing to discuss that with them and do the repeat operation. Okay, tumor implantation at the time of TURBT. This is the theoretical concept. During the conduct of surgery, are we shedding tumor cells in a hostile bladder that now has a strong inflammatory effect from the conduct of the surgery, other parameters of moving the scope around, blunt trauma? Do those tumor cells have an advantage, a microenvironment that becomes a favorable host that they can implant and start to develop a new tumor at that site or the original site? So that's the theory. That's the leading theory behind why we give that perioperative dose of intravesical chemotherapy. Around the year 2000, there was a meta-analysis, again done by the EORTC group, on this topic about suggesting to all practicing urologists worldwide, after every TURBT operation, we should give that perioperative dose of intravesical chemotherapy. It kind of makes life easy in the sense that as long as you have the workflow down and you're ready to do it, just give it after every operation. Well, there were several studies that came out after that, randomized trials around the world, that started to demonstrate that maybe not every patient population benefits from that perioperative dose of chemotherapy. So the EORTC went back to the original publication, had additional trials added to the original meta-analysis, got individualized patient data, which improved the strength and quality of their meta-analysis. And they came up with a new recommendation and agreed not every patient with bladder cancer who's having a TURBT benefits from that perioperative dose. And their recommendation is that if the EORTC score was greater than or equal to 5, that patient doesn't benefit from the perioperative dose because they're going to go on to additional intravesical therapy. To make it easy in a practical world, the way one should read this is low-risk non-muscle invasive bladder cancer patients absolutely benefit. A significant proportion of intermediate risk bladder cancer patients, or essentially the way I look at it, is all intermediate risk non-muscle invasive bladder cancer patients could derive benefit from the treatment, and high-risk patients don't. So that's the practical approach that I utilize in my practice and whom I'm considering giving that perioperative dose. So you have to use your judgment. Sometimes you don't know which patient has intermediate risk disease at the time of the TURBT and so forth. Sometimes you do with high confidence. Bottom line is just use your judgment. There's no harm in giving it, and later it turns out to be a high-risk patient, or I should say there's very little risk of giving that perioperative dose, but at least you were thoughtful about it and you had good justification about why you gave the drug at the conclusion of the operation. And this you're probably very well aware of. I wouldn't say it's the new standard, but I think it's a practice pattern we all have adopted. And the drug we're using in the perioperative setting now is gemcitabine and not mitomycin, um, because of the fact we all feel it has a better safety profile in giving it in the perioperative period. So I think the majority of practitioners have moved on from giving mitomycin as the drug of choice, but rather gemcitabine. And this is the trial that led to the adoption of giving gemcitabine. Is a really nicely done trial by the SWOG cooperative group looking at gemcitabine versus placebo in the low grade um, TA tumor population, demonstrating that there are reduced recurrence rates with gemcitabine. And so I think this is probably the standard. I'm assuming that probably you use at your institution, likely like many others, but there's no evidence that one chemotherapeutic is superior to another. So regardless of what you use, in Europe they mostly use epirubicin. That perioperative dose of chemotherapy is important in a given subset of patients. Okay, I'm going to move on to the next topic. And it's really the urothelial field change or Slaughter's concept. And I'm just going to describe this briefly for a moment, just to put it in context. So I've kind of talked about recurrence rates and just my very general view. Why does it happen? Because of persistent or unrecognized tumor at the resection, because of the theoretical risk of tumor implantation. We have clinical strategies on how we improve in those areas that I've highlighted. The third area is urothelial field change. This is the classic body of literature that has now evolved into more sophisticated level of evidence that's been published in high impact journals like Science recently, that looks at individuals in the population who don't have a history of bladder cancer, as well as individuals with a history of bladder cancer. If we look cystoscopically at areas that are absolutely normal by white light and blue light cystoscopy, if you biopsy those areas and you interrogate them at a level of mutations in the DNA, change in methylation profile or epigenetics at the level of tumor suppressor gene promoters, if you look at other type of um, um, genomic type of evaluation of genomic copy number changes, you'll find there's evidence that demonstrates to us there are changes that happen in our cells of our epithelium of the bladder because of the process of aging, maybe because of an influence of carcinogenesis on top of the process of aging. But even in bladders from individuals on autopsy studies, you can see changes at the DNA level. And some of those changes are associated with well-known cancer alterations, like certain oncogene mutational events. That level of interrogation in bladder cancer patients, those incidence of those changes is higher than the general population. So that's Slaughter's concept. It wasn't developed in bladder cancer. It was looked at in field defect in the throat of individuals affected with throat cancer. And it's been looked at in the colon, it's looked at in the stomach, it's been looked at in the bladder, it's been looked at in the prostate. There's field change going on. How much that influences subsequent cancer risk or the development of cancer is clearly not entirely known, but a real important concept, and a lot of fundamental research is going on in that topic. Well, that's why I put up this next, that's why I move on to this next section, intravesical therapy. What is intravesical therapy doing? Well, I want to start with a point that when I was a trainee, when I was a resident, and kind of the message that I thought I heard, and maybe I wasn't hearing correctly, is intravesical therapy is commonly done to treat residual cancer in the bladder, active cancer, whether that's microscopic, maybe even I would suggest gross tumor. The operation did the best we could at getting out the tumor. Some was left behind. It was thought to be a challenging operation. We did the best. Let's give BCG. It'll kill the tumor. The reality is, if we look into the data about intravesical therapy's ability to kill active visible tumor, microscopic tumor, we can demonstrate that it's not that successful, or we can't measure that concept of microscopic residual tumor. How do we know if intravesical therapy is impacting that? It's pretty hard to measure, a hard study to do. So in some contexts, possibly it has a role in treating residual cancer. But the real intent of intravesical therapy is to treat the field change. It's to prevent tumor recurrence. And that's really the rationale behind why we give intravesical therapy. It's treat that field effect. So I'm going to move on to intravesical therapy, but I just bring that up as something for you to think about because we are very clinically oriented. We sit down with our patients, we've done a good operation, we have our operative report, we've used our checklist, we have the pathology back. We put our patients into categories. And this is what our guidelines advise us to use risk stratification based categories. And that's these terms that you and I use: low risk non-muscle invasive bladder cancer, intermediate risk NMIBC, and high risk NMIBC. And you see the tumor types that populate those risk groups. And this is the version from the AUA SUO guideline. There is a little bit of variation with the European guideline, the Canadian guideline. They're very similar, the risk stratifications, but there are some nuances about how the groups bucket the different tumors. But this is very useful. If we sit down and we have those variables of the things I mentioned, we can now put our patients into a risk category. So for low risk patients, what do we tell our patients? Well, this was an individual that had a single papillary tumor in the bladder, fully resected. It was less than 3 centimeters in size. The pathology came back low grade TA. We all know that's a very indolent tumor. That's a very warm visit with the patient. It's a visit the patient feels real good. There's very little risk of tumor recurrence, very little risk to no risk of tumor progression. It's recommended no further intravesical therapy should be given in this patient population. We did the operation, we gave the perioperative dose of chemotherapy. We now put them on a surveillance schedule. So that category is pretty straightforward. The intermediate risk category, I do want to spend a few minutes going over this category. The reason I want to bring this up, again, I want the approach today to be fairly general. I want to stay away from too much nuanced discussion, too much detail, too much overwhelming data or references to publications. But this is a category that is receiving a lot of attention in the field of urology for good reason. It's a conundrum in clinical practice. There's so much heterogeneity. The low risk group is pretty straightforward, what we just talked about. The high risk group, which I'm just going to share one real simple slide after this section. And really, that's that category of high grade tumors, high grade TA, high grade T1, carcinoma in situ. I mean, that category is pretty straightforward. We pretty much advocate BCG with maintenance therapy. Everything else falls in the intermediate risk category. And so I'm going to highlight a very common clinical scenario. 78-year-old gentleman, several medical problems, history of low-grade TA urothelial cancer, had 2 tumors. They were relatively small in size, underwent his first TURBT 12 months ago, and had that diagnosis. Follow-up, everything was going well. A year later, has new papillary tumor recurrences. So what do? Classic approach, what we commonly do today naturally, is we schedule a patient for an operation. There's recurrent papillary tumors, and so we take them to the operating room. So if we have it available, hopefully we do, we'll use blue light cystoscopy to improve our rates of tumor detection. We'll remove all the tumors. We'll give the perioperative dose of chemotherapy. I'll use gemcitabine. We get the pathology back. It's low-grade TA bladder cancer. So problem is cured. What do? Well, the first thing I put there is questions. I kind of just bring that up for redundancy again. We would love to counsel our patient on what's the risk of tumor recurrence and progression. So we have a few tools out there. The ORTC table I mentioned isn't the best. There are a few other tables out there. None of them are very accurate. So we don't have great tools to really be able to be that specific with our patient. So we use generalities. And we often do our best to pick numbers that we feel like we know them from some type of literature or update or something we read, and we present the data. So we do our best. So what does the AUA recommend for intermediate risk patients? What should we do next? Well, the AUA recommends you should give intravesical therapy to reduce the risk of tumor recurrence. This again is treating that concept of the field defect. And sure, there are studies that show even in low-grade TA tumors, when you completely remove them at repeat TURBT, you might find a little bit of residual low-grade TA cancer left behind in a certain percentage of patients. So maybe the drug benefits there as well. The AUA tells us you have the option of intravesical chemotherapy or immune therapy, which is what they're referencing as BCG. It's a pretty strong recommendation, evidence strength grade B. Well, this is a group that I think has done a lot of good for the field of urology in the space of bladder cancer. It's the International Bladder Cancer Group. They're a very thoughtful group of individuals who have dedicated most of their career to the treatment of bladder cancer. And their recommendations were recently adopted by the NCCN Bladder Cancer Guideline. This is their 2022 publication. They had a follow-up publication on this same topic in 2024, and now the NCCN has adopted their schema. Now there's been some validation by other groups of their original recommendation that, boy, this intermediate risk population is real complicated because risk of recurrence is so variable. It's impacted by how many tumors were in the bladder, how many recurrences have they had before? How quickly did they recur? What were the size of those low-grade TA tumors? And by the way, have they failed previous intravesical therapy they might have received? So there's so much heterogeneity from a real simple patient to 1 centimeter tumors to someone that had 12 TA low-grade tumors that were 3 centimeters in size, 5 centimeters in size, and you gave them BCG before. The risk of recurrence is so different between those two exaggerated examples, but they're both intermediate risk. So they came up with these 5 criteria, suggested that we should be saving BCG for the highest risk patients or when you fail chemotherapy because it is such a valuable resource. We have a shortage. There's a lot of equivalency in the two drugs, chemotherapy versus BCG. So they made a suggestion. This was adopted and validated by several institutions in prospective studies. The NCCN has now adopted it. And this is something I just share with you today that I hope you have a chance to look at some of the updated guidelines. They're all starting to come out from the NCCN now. This is the time of the year where amendments are starting to be made and new guidelines will start to come out over the summer. And this is something I think you should implement in intermediate risk patients when you're thinking about, should I give them chemotherapy? Should I give them BCG? Should I give them maintenance? Should I not give them maintenance? I think it's real important to highlight that. I want to take this case a little bit further in the intermediate risk space. I want to highlight things we should all be thinking of. This has changed in my own practice in the last 5 years. What I shared with you so far, the case example, that's what I did every time a patient with intermediate risk bladder cancer recurred. What did I do? I took them back to the operating room. I wanted to do a good job, high quality TURBT every time. Well, things are changing. I think we're realizing we don't have to operate on everybody. How about just monitoring those tumors? I'm going to go through the slides relatively quickly. I shared my talk with Dr. Jenkins. You're certainly all, you all can have my slides. I shared it for you as a resource. So if you want to look at the references, look at the slides, please do so. Again, I've shared the slides. I hope you can put them in your resource library and utilize them. So I'm going to go through them relatively quickly. This is an Italian group. They've done a prospective study of looking at low-grade TA tumors. And what if we just observe them? So they set criteria of a cohort of individuals that they felt it would be appropriate. So they chose less than or equal to 5 tumors, all less than 1 centimeter in size, negative cytology. They're known to have low-grade TA bladder cancer. So you're confident that the new recurrence is very likely to be low-grade TA, and you use a lot of judgment cytology to get confidence in that. You even biopsy one of the tumors, prove they're low-grade. Well, they put them on a study. There are many retrospective studies. This was demonstrated by multiple authors, institutions. It's a safe approach, but they were retrospective, small cohorts, not a lot of enthusiasm to adopt that approach. Well, they've been following a series of patients for a considerable period of time, and they're starting to demonstrate that it's very safe to observe patients. They rarely become symptomatic with bleeding or other concerns, and the likelihood that the tumors are misdiagnosed or progress to high-grade tumors is not very high. That active surveillance and monitoring tumors is something we should all strongly consider. So that's something I'm utilizing in my practice relatively often, and I just bring it to your attention. There are several studies out there. They have different criteria. Who's to say it should be 5 tumors? Why not 7? Why not 3? Why do they all have to be less than a centimeter? Why not less than 1.5? We can debate all of this. There's no hard and fast rules, but I think it's something to think about. Why not? I think we're all very well aware of this very attractive concept. Why do surgery? Can we not use a drug to destroy the tumors? Why not a chemotherapeutic in the bladder? Can it actively kill tumors? I said earlier, the high grade tumors, we have to be cautious when relying on BCG. It's different in the low grade population. There are studies that are called target lesion studies that demonstrate for considerable period of time historically that low-grade TA tumors can be killed by chemotherapeutics. There's a trial that was done in Scandinavia that was a nice randomized trial, a really cheap trial. What they did is instead of the classic TURBT followed by adjuvant mitomycin C, the classic approach I've been utilizing in my practice, why not take the very cheap drug mitomycin? Let's give it 3 times a week for 2 weeks. So meaning let's give a lot of repetition, a lot of dosing instead of doing the TURBT. And they demonstrate a lot of tumors were killed that way, and you could avoid the TURBT operation. And I'm going to move right through the data into this. So we're all very aware of the new FDA approval of the product by Urogen, the chemoablative drug that we can use for bladder tumor. This is a series of trials that the sponsor of the trial who developed the hydrogel that mitomycin is embedded in, UGN 102, that led to FDA approval. And so you probably are aware of the Envision trial, and is published in the Journal of Urology. It was presented at several national meetings. It's been reviewed by the FDA, and it now has approval as a chemoablative or chemoresection in lieu of doing a TURBT. And the evidence is pretty striking, very much like the De Blacca Scandinavian study, with a very cheap approach to mitomycin, that you can kill tumors. And you can prove that at the first follow-up cystoscopy, the tumors are gone. Now, it's not for every patient, and I won't get into that today, but certainly it's something to think about. And finally, something else to think about, why not treat the tumors in the office? Why go to the operating room? If you have a patient with several comorbidities, maybe a patient on blood thinners, a patient who doesn't desire to undergo an anesthetic, well, this has been an evolving discussion for many years, published, a plea for urologists following these publications. Why do we take patients with intermediate risk bladder cancer back to the operating room for TURBTs? Why not treat them in the office with office fulguration? It's really not that complicated, but there is quite a bit of work to implement it in your practice. You have to have a streamlined team and setup. You want it to be relatively seamless and proficient and be efficient at doing the procedure. You don't want to spend 2 hours of your workday, working on, one situation of fulgurating 2 tumors. So it does take some effort to have this set up in a clinic setting. And certainly I've been doing this for a number of years in the office. So I'm going to highlight again the intermediate risk patient population, very heterogeneous. We have many options of treatment now in addition to TURBT, followed by adjuvant chemotherapy or BCG. Why not just observe them in the right population? Why not consider office fulguration? And then how about the newly approved chemoablative mitomycin hydrogel? So lots to think about in this space as you see patients and go through your curriculum. Here's my one very simple slide on high risk. I won't get into the details here. And I think we're all very aware this is strong level 1 evidence. High risk bladder tumor patients following confidence in removing all signs of disease should receive induction plus 3 years of maintenance therapy as they're able to tolerate it on the SWOG protocol. The last thing I want to bring up for the last 2 minutes before I wrap it up, and hopefully there'll be some questions and dialogue. Some non-muscle invasive bladder cancer patients, bladder sparing is risky. Radical cystectomy should be part of the conversation and patient counseling. And when should that be? I'm again going to take a very simplistic view, a high general view like I have for most of my talk. It's when not removing the bladder presents a loss of an opportunity to cure the patient. This slide was shared with me by Dr. Kamal at MD Anderson, a very close colleague of mine. He had this in a presentation a number of years ago, but you see a prostate cancer patient characteristics. The risk of death of that patient worries us when we see numbers like that. Well, a high-grade T1 patient over their lifetime has a similar mortality rate. So it's a very serious disease. I put it together in one simple cartoonish slide with some color. When should we be thinking about bladder removal surgery, radical cystectomy in this space? I'm going to start in the bottom right. This is from AUA guidelines, EAU guidelines. It's with patients with multifocal high-grade T1 bladder cancer with carcinoma in situ. You need to think about it because the risk of recurrence, but more importantly, progression of that patient to muscle invasive bladder cancer in their lifetime is not small. Prostatic urethral involvement with invasive disease. Need to be cautious and careful about that patient, that they recognize that that's a predictive parameter. They have a higher risk of progression than other types of individuals affected by T1 bladder cancer. Lymphovascular invasion. It's been demonstrated in several reports, including a high impact publication in the journal Clinical Oncology. The highest predictive variable other than depth of T1 bladder cancer invasion for the risk of progression is if there's lymphovascular invasion in that tumor. Certain histologic subtypes like micropapillary bladder cancer, plasmacytoid, we should always bring that up. And finally, this space that's really evolved and there's so much activity, the BCG unresponsive population of bladder cancer. And I'm going to wrap it up there. So appreciate everyone's time today. I hope that was fruitful and understandable, and certainly I would love to take any questions.
Dr. Pohar, I had two questions. The first one is for the intermediate risk groups. One of the things that you were saying are general principles is that, this idea of urothelial field change. I guess some of the surrogate markers for the risk factors that they publish, like, the number of tumors, the size of the tumors, even for let's say multifocal low-grade recurrence might increase your risk.
Yes.
Are they surrogates for that urothelial field change that you're anticipating on a genomic level? Because I guess I've always struggled with the fact that how is a low grade any different, right? Because at least genomically, the low grade cancer has a different mutational process through FGFR3 versus like a high grade cancer. Or is it that there's a different spot in the bladder that we haven't seen yet that has had this genomic change that makes it a higher risk to progress into a higher grade cancer that we can't actually visualize, but then will cause the eventual recurrence of someone who's been low grade to a higher grade? That's my first one.
Yeah, I think your point's a good one. I think if I understand it correctly, is it's this concept of, is the drug really being utilized for residual disease, whether it's visible, that just was missed, or is it microscopic residual cancer versus treating this field change effect? So it's still a little controversial about, how can you prove that the field defect Slaughter's concept is improving with intravesical therapy. But it makes a lot of conceptual sense that that's why the drug is being given. But even low-grade patients, if you look, if there hasn't been studies very uniformly in patients with low-grade, the studies are skewed towards measuring that field defect more in the high-risk population, not as much in the low-grade. But there is that population-based autopsy study that I referenced, and that included even individuals in their 30s and 40s. And they started to demonstrate that there were it's published in Science if you're interested. There are two publications from two groups, one from China and one from Europe, and they put them together in one journal. And the study designs were a little different, but they demonstrated that there are mutational changes and in just the general population, and some of them are FGFR3 alterations.
Thank you.
Did that answer the question? I'm not really sure it did.
Yeah, I think it did. And I guess my second question is for this very high risk, like non-muscle invasive bladder cancer population. Remember, we still counsel people for upfront cystectomy, or talk to them about it at least, versus intravesical therapy, and we're still doing that currently. But does any of the, I guess, I know it was only studied in muscle invasive bladder cancer patients, but like 905, does that change how you counsel these people? Because or is there a risk that they'll progress so fast that you won't even catch them at the muscle invasive stage? You might catch them before it like spreads past the bladder, or given how successful EV Pembro has been in the perioperative phase, these people wouldn't be considered candidates for EV Pembro or any adjuvant therapy if you offered them upfront cystectomy.
Yeah, and so there's no doubt. This slide that I just left up on the screen right now. We're taking out a lot. If you adopt this approach, naturally, there are some individuals in whom it'll benefit them significantly. Keeping them away from progressing to muscle invasive disease, despite the fact we have an evolution of newer drugs, potentially better outcomes. Still, there are people who die when you progress to muscle invasive disease, and the amount of morbidity from all of the systemic therapies, ongoing immune therapy in the adjuvant setting, the long-term follow-up. There's a lot going on in this space. So there's no doubt we're taking out too many bladders. Even if you use these criteria, many of these patients don't need the operation, because it makes me feel silently it's on my conscience. Did the patient really need their bladder out? The guidelines tell me, the evidence that's available strongly suggests to me I should have brought this up. I should encourage it in certain patients. But I think your point, to piggyback on some of these trials, there's a lot of enthusiasm. We're far from it. But can we avoid the cystectomy? You brought up the EV Pembro. I'll bring up the Niagara data now that we've moved on from gemcitabine cisplatin. We've now added an immune therapy on top of that. We've realized that adding that and then continuing it in the adjuvant setting, we get better outcomes. There are more lives that are saved. EV Pembro now is a new option in the cisplatin ineligible space. And so we're very enthusiastic about wanting to know in the muscle invasive patients, can we avoid cystectomy? And the tools we're using are ctDNA, so measuring, can we identify tumor cells in the blood, and urinary tumor DNA is kind of another evolution that's going on. So in addition to our tools of do a CAT scan, take them back to the operating room, rebiopsy the site, biopsy the scar, can you prove there's residual tumor, get a cytology? If all of that is negative, we're still not confident that the patient doesn't have residual cancer. So now we're layering it with ctDNA. We're starting to layer that with urine tumor DNA. We're trying to do everything we can with modern tools. Can we demonstrate this individual has no residual cancer? And can we avoid a cystectomy? This is what's the conversation is now starting with this high risk NMIBC space, because you can detect tumor DNA in NMIBC patients, which was kind of surprising to me. But the publications are coming out. Groups are now publishing that you can find tumor DNA in the blood of NMIBC patients. And clearly, we're starting to demonstrate urine tumor DNA, which is a reflection of residual cancer after TURBT. So I think this is where the field is going.
My name is Jacob. I'm one of the third years. You showed us some of the principles about working a patient up and afterwards, but can you kind of walk us through how you approach the actual surgery of a TURBT? Is there any principles that you follow for yourself?
I do. What I'm going to say is they're my personal approach of having done more than 4,000 TURBTs now, since really all I do is bladder cancer, always wanting to get better. So, I divide the bladder up into sections. And I work on areas of the bladder that are less complicated to get the operation started. I like to do that because every day you walk in an operating room, there's a little bit of nuance about the equipment every day, your flow dynamic. I use continuous flow. I should qualify that. I'm a big advocate of continuous flow resection. I know not everybody advocates that, but your inflow, outflow that day, we use the Neptune as our suction device. So I like to get the room set, make sure that everything is very functional, that I kind of have a sense of this patient's anatomy, their bladder, what their filling capacity is like, where I want the outflow at various times during the surgery. And I'll warm up and kind of get started with an area of the bladder where the tumors are a little easier to resect. So, the easy ones for you and I, where we're generally pretty relaxed, are posterior wall, on the lower posterior wall, trigone area, where there's little torquing of the scope. So that's I'll get started there. I'll get one section done real well, make sure I got muscle. That starts to give me a sense of how thick are the muscle bundles in this patient, because they're going to be the same everywhere. So you get a sense of the thickness of the muscle bundles, where that where the deepness is going to go. Then I'll move over to another area. And I think it's real important you separate specimens individually as much as you can, because it's important to build this pathologic evidence. This slide again that I have left up here, it's important to know, do you have multifocality of T1, or was it just one area of T1 and TA? Unless you're separating it, you don't really know. So that's my strategy. I'll build it in sections. I'll build confidence in my equipment, my comfort level with that patient's body habitus anatomy. Then I'll move to another area that's more challenging. Then I'll move to another, and so on and so on. And I'll just keep moving around, based on my comfort level. And if there's any point in the operation where I think it might be getting out of hand, where it's getting a little complex, the resection's been lengthy, you're already at 75 minutes of actual resection time, patient's anatomy is challenging, the debris is starting to form, there's no harm. It's in the patient's best interest. Stop the operation, come back in 3 or 4 weeks and complete the surgery. And it's often valuable. You get your pathology back in the meantime. You might start to recognize maybe cystectomy is best to discuss and another TURBT is not necessary. There are ways to get better. I mean, I think you should measure yourself whether you have muscle in the specimen, in each of the specimens you're collecting in that. I think that's an easy starting point. I think you should use a checklist. It's highly valuable. It will start to make you better. It made me better, a simple tool like that. It pushes you to get better.
Yeah, I think it's something that I'll start. What's your opinion on en bloc resections?
Yeah, it's good. It's an evolving field. It's shown up at many presentations at national, international meetings, and there are publications that are out there. With en bloc, there are several technological approaches. So many approaches have been described. Some of them, they've developed a new device like a lasso, where you lasso a tumor, it creates a big ring or burn mark, and it lifts the tumor up. to simplistic approaches. You just take your holmium laser, go in and start raising the base of the tumor in the muscle and just raise it. They're always focused on generally single tumors, less than 3 centimeters in size, is what the study design has mostly been.
Right.
The studies have really been done in Europe. We're very anxious and optimistic to start to do some of those studies in the United States. So it's being discussed at many trial cooperative group networks. So we're talking about it. It's not ready for prime time, so to speak. We're far from it. There are some nice systematic reviews on the topic by authors who are very knowledgeable in the field. And the conclusion always is, like a lot of things, it's promising. We don't have the full evidence that it's better than what we're doing now, like presence of muscle, equivalent resection, it's safer. But the signs are it potentially could improve outcomes in the future. And we have to do more studies, and we have to start to find technologies to include more patients other than the single 3 centimeter tumor.
Gotcha. Thank you so much. It's fantastic. Thank you.
Thanks for the question. Anyone else?
All right.
Okay.
Thanks, Dr. Pohar, for a great talk and for spending your time with us this evening. I know all the residents appreciate it. So thanks again.
Nice to see you all. Hopefully I'll see you around one of the meetings. And please use my slides if you think they're valuable to you. Take care.
Thank you.
Thanks. Good night.